Hello everybody, dear colleagues. Department of Endocrinology, Phyllis State Medical University presents the lecture Hypothyroidism. Lecture is given by the head of the Endocrinology Department of Phyllis State Medical University, Professor David Metravelli. Hypothyroidism. Hypothyroidism results from insufficient secretion of thyroid hormones. It may be primary, which characterized by low serum free thyroxine and high serum thyroid stimulating hormone TSH levels due to a reduced negative feedback effect of T4 on TSH synthesis or secretion. There are different degrees of hypothyroidism. For example, in case of subclinical hypothyroidism, there is a normal serum-free T4 and T3 levels in the blood, but high serum TSH. This reflects the sensitivity of TSH secretion to very small decreases in thyroid hormone secretion. Hypothyroidism may be central. Central hypothyroidism is much less common and results from reduced TSH secretion from the anterior pituitary. It's a so-called secondary hypothyroidism, or reduced TSH hormone secretion from the hypothalamus. It's so-called tertiary hypothyroidism. And what about epidemiology? For example, the prevalence of congenital hypothyroidism is about 1 in 4,000 of the newborns. And the frequency of hypothyroidism varies from 0.1% to 2% in adults. Hypothyroidism is 5 to 8 times more common in females. And primary hypothyroidism accounts for more than 95% of cases of hypothyroidism totally. Around 5% of adults and 15% of women over the age of 60 have subclinical hypothyroidism. Subclinical hypothyroidism may result from the same causes as the primary hypothyroidism or from inadequate T4 replacement in a patient with overt hypothyroidism. Congenital hypothyroidism. It may be secondary to steroid agenesis, degenesis, or inherited defects in thyroid hormone biosynthesis. Autoimmune thyroiditis and hypothyroidism. Chronic autoimmune thyroiditis, so-called Hashimoto's thyroiditis, is caused by the cellular and antibody-mediated injury to the thyroid tissue. There are two forms, goitrous and atrophic, which have similar pathophysiologic but are different in the extent of thyroid follicular cell hyperplasia, lymphocyte infiltration, and fibrosis. Chronic autoimmune thyroiditis is usually, but not always, permanent. These patients are more likely to have a personal or family history of other autoimmune conditions, such as Addison disease and type 1 diabetes mellitus, also vitiligo, pernicious anemia, and premature ovarian failure. An increased incidence of Hashimoto's thyroiditis is also found in those with Down's or Turner syndrome. Pharmacological agents and hypothyroidism. Drugs such as the antithyroid drugs, carbimazole or propyltiuracil, which are used to treat hyperthyroidism, they may cause hypothyroidism. Amiodarone is an iodine-containing drug and may cause both hypothyroidism and thyrotoxicosis also. Other drugs that may cause hypothyroidism include the lithium, alpha interferon, and interleukin-2. Patients in these drugs should have their serum TSH checked every 6 to 12 months. Surgery and hypothyroidism. T4 had a half-life of 7 days, and hypothyroidism occurs about 2 to 4 weeks following total thyroidectomy. After subtotal thyroidectomy, for the treatment of Graves' disease, hypothyroidism occurs within the first year in the majority of patients. The annual risk of hypothyroidism in those who are euthyroid at 1 year is 0.5 to 1%. Some patients became transiently hypothyroid after 4 to 8 weeks, but recover several weeks or months later. Irradiation and hypothyroidism. Following radioiodine therapy for the treatment of Graves' disease, the majority of patients became hypothyroid within the first year. The rest have a 0.5 to 2% annual risk of hypothyroidism. Some patients with toxic multinodular goiter or thyroid adenomas who receive radioiodine therapy also became hypothyroid. External irradiation of the neck may result in hypothyroidism with a gradual onset. Many patients developed overt hypothyroidism after several years of subclinical hypothyroidism. And very interesting is the problem of iodine and hypothyroidism. Iodine deficiency and excess can both cause hypothyroidism. Iodine deficiency is the most common worldwide cause of hypothyroidism and is more prevalent in mountainous areas. Iodine excess can also result in hypothyroidism by inhibiting iodine organification and T4 and T3 synthesis, so-called Wolff-Chaikoff effect. Hypothyroidism, in any cases, may be transient. For example, in postpartum and subacute thyroiditis, transient hypothyroidism lasting weeks to a few months may follow transient thyrotoxicosis. There are any rare causes of hypothyroidism. For example, these rare causes include infiltrative disease, for example, fibrosis, rheoids, thyroiditis, hemochromatosis, sarcoidosis, amyloidosis, leukemia, and consumptive hypothyroidism due to an ectopic production of the type 3 deiodinase in vascular and fibrotic tumors, which metabolize T4 to reverse T3. So, among causes of hypothyroidism, it's a congenital hypothyroidism because of thyroid agenesis, dysgenesis, or inherited defects of thyroid hormone biosynthesis. Hypothyroidism may be acquired. It's a primary when there is a chronic autoimmune Hashimoto's thyroiditis, or maybe iatrogenic because of action of drugs, after thyroidectomy, radioiodine, neck radiotherapy. Iodine deficiency in excess also results primary hypothyroidism and thyroiditis. Hypothyroidism may be central, pituitary hypothalamic damage, for example, due to tumors, trauma, radiotherapy, hypophysis, infarction, infiltration. Clinical presentations of hypothyroidism. Hypothyroidism often has an insidious and non-specific onset. Patients may present with fatigue, lethargy, and cold intolerance. Clinical presentations of thyroid hormone deficiency result from a generalized lowering of metabolic process and an accumulation of hydrophilic glycosamine glycans in the interstitial space of the tissues, so-called mixed edema. In secondary hypothyroidism due to hypothalamic pituitary disease, these symptoms are usually milder than in primary hypothyroidism and may be masked by symptoms of other hormone deficiencies. For example, hot flashes secondary to hypogonadism may make the cold intolerance caused by the hypothyroidism less obvious. General presentations of hypothyroidism, it may be tiredness, cold intolerance, depression, goiter, changes of skin and hair, dry skin, coarse, decreased adrenal gland secretion, edematous, and so on. Very important are cardiovascular manifestations, bradycardia, exertional breathlessness and reduced exercise tolerance, maybe changes of diastolic hypertension because of increased systemic vascular resistance, pericardial effusion, and hypercholesterolemia and hypertriglyceridemia because of decreased lipid metabolism. It's an appearance of patients with hypothyroidism, with edema, mixed edema. Respiratory manifestation, hypoventilation, obstructive sleep apnea, and pleural effusion. Gastrointestinal manifestation, especially constipation, because of decreased gut motility. Weight gain, because of reduced metabolic rate and accumulation of glycosamine glycan-rich fluid. And ascites, changes of reproductive system, hyperprolactinemia, high tyrotropin-releasing hormone in primary hypothyroidism stimulates the prolactin production. In women, oligomenorrhea, amenorrhea, or menorrhagia, early abortion. In men, reduced libido, erectile dysfunction, delayed ejaculation, reduced serum total testosterone due to low sex hormone binding globulin levels. Neurological features, slowing of intellectual activity, movement and speech, impaired memory, delayed relaxation of deep tendon reflexes, and so on. And myxedema coma may present with coma, hypothermia, hypercapnia, and hyponatremia, and it's a very dangerous condition. Anemia, normocyte anemia, macrocyte anemia, and so on. Metabolic changes, hyperlipidemia, hyponatremia, reduced cardiac output sensed by the carotid sinus baroreceptor can result in increased antidiuretic hormone release. Also, decreased glomerular filtration results in reduced free water excretion. And also in patients we have hyperhomocysteinemia. Which investigations are necessary? The diagnosis of hypothyroidism is made by the measuring serum TSH and free T4. In many developed countries, congenital hypothyroidism is diagnosed during the routine screening of all infants by measuring TSH or T4 in blood obtained from a health brink in the first week of life. The next slide shows the results of thyroid function tests in primary, subclinical, and secondary hypothyroidism. In general, younger patients presenting with primary hypothyroidism have much higher TSH level than older patients. In this table, we see that in primary hypothyroidism, TSH level is increased, free T4 level decreased, and free TSH level is decreased or maybe normal, low normal. In case of subclinical hypothyroidism, TSH is elevated, but free T4 and free T3 levels both are in normal range. In case of central hypothyroidism, TSH is low or inappropriately normal, but free T4 is low and free T3 is low or in cases maybe near normal. Among other laboratory tests, we can see the hyperlipidemia and hyponatremia. Diagnosis tests for central hypothyroidism. Patients with central hypothyroidism should have pituitary function tests and a magnetic resonance imaging scan of the hypothalamus and pituitary. A TRH test may occasionally be done to differentiate between pituitary and hypothalamic causes of the TSH deficiency. A dose of 200 micrograms of TRH is given intravenously over 2 minutes. Blood samples are taken at 30 and 60 minutes. The 60 minutes value exceeds the 30 minute value in hypothalamic hypopituitarism. Primary enlargement in primary hypothyroidism, pituitary enlargement in primary hypothyroidism. Pituitary enlargement may occasionally be seen in severe pituitary hypothyroidism owing to hypertrophy and hyperplasia of the thyrotroph cells. It is important to distinguish this entity, which is reversible within T4 replacement, from a pituitary adenoma. Treatment of hypothyroidism. Hypothyroidism usually requires lifelong treatment with synthetic levothyroxine. Exceptions include cases of transient hypothyroidism following subacute or postpartum thyroiditis, or reversible hypothyroidism due to a drug that can be stopped. Treatment objectives are the resolution of symptoms, a normalization of TSH, and a reduction in the size of the goiter in patients with Hashimoto's thyroiditis. There is no proven benefit in using a combined T3-T4 replacement. Dose and administration of levothyroxine. In younger patients under 50 years, can be started on levothyroxine 50 micrograms daily. Thyroid function tests are repeated after 6 weeks, and the dose is increased by 25 micrograms until the TSH is in the normal range, and ideally is close to 1 milli-unit per liter as possible. In all the patients, all the patients should be started on a lower doses, usually 25 microgram or 12 microgram, as they may have ischemic heart disease, and levothyroxine increases myocardial oxygen demand. the dose may be gradually increased. However, a suboptimal replacement may have to be accepted if an optimal dose causes cardiac symptoms. The average dose of levothyroxine in hypothyroid adults is about 100 microgram per day, but the range varies from 50 to 200 microgram daily. It is important to advise patients on the potential adverse effects of levothyroxine over replacement, such as arrhythmias and osteoporosis. Levothyroxine should be taken on an empty stomach, and medications that interfere with this absorption, for example, ferrous salt, cholestyramine, should be taken several hours after the levothyroxine dose. Some drugs, for example, phenytoin, carbamazepine, may increase levothyroxine metabolism. Patients with poor compliance with the levothyroxine replacement may occasionally receive their total weekly dose of levothyroxine once per week. This should probably be avoided in coronary heart disease. Follow-up and monitoring. Levothyroxine has a half-life of 1 week, and it takes about 6 weeks, 6 half-lives, to reach a steady-state concentration. Serum T4 increases first, and then TSH secretion starts to fall. Follow-up appointments for clinical assessment, measurement of thyroid function, and adjustment of the dosage should be arranged every 6 weeks. After stabilization of TSH levels and establishment of the proper maintenance dose, clinical assessment and serum TSH measurement should be carried out annually. When levothyroxine is commenced, TSH occasionally rises further initially before it starts to fall. It may be because the pituitary itself has begun to suffer from the profound hypothyroidism and has failed to make TSH. On commencement of the levothyroxine, the pituitary starts to recover. It is worth noting that hair loss may initially be made worse by commencing levothyroxine. This is because new hair follicles start growing and push up the old hair follicles. It may take about 9 months before this stabilize. Suspected adrenal insufficiency. Levothyroxine replacement in patients with untreated adrenal insufficiency can precipitate an additional crisis. A short synoxane test should always be done prior to levothyroxine replacement if adrenal insufficiency or secondary hypothyroidism is suspected. Hydrocortisone must be given with the levothyroxine estrogen therapy. Estrogens may increase the need for levothyroxine. In women receiving levothyroxine replacement, serum TSH should be measured about 12 weeks after starting estrogen therapy to determine whether an increase in levothyroxine dose is needed. Surgery. Patients on thyroxine replacement who are unable to eat or drink following surgery should receive intravenous levothyroxine, and daily dosage should be decreased. At about 80% of oral dosage is needed, only if they have not resumed oral intake after 5 to 7 days. And transient hypothyroidism. Transient hypothyroidism, for example, following thyroiditis, can last from a few weeks to as long as 6 months. Patients with minimal symptoms may not require therapy, but symptomatic patients should receive levothyroxine for several months. A normal serum TSH level 6 weeks after stopping levothyroxine indicates a recovery of thyroid function. And hypothyroidism in pregnancy. Hypothyroidism in pregnancy is associated with several complications, including early pregnancy loss, placental abruption, preeclampsia, preterm delivery, low birth weight, perinatal mortality, and neuropsychological impairment, which may occur even in women with subclinical hypothyroidism. Treatment and follow-up hypothyroidism in pregnancy. If hypothyroidism has been diagnosed before pregnancy, the preconception levothyroxine dose should be adjusted to reach TSH level of less than 2.5 milliunits per liter. As mentioned above, T4 requirements increase during pregnancy. However, women with hypothyroidism are unable to increase their T4 and T3 secretion. Therefore, the dose of levothyroxine should be increased by 30 to 50% by the 4 to 6 weeks gestational. Serum TSH should be measured 4 to 6 weeks after conception, 4 to 6 weeks after any change in the dose of levothyroxine, and at last once each trimester. Further dose changes are based upon serum TSH concentration. Aim for a serum TSH of less than 2.5 milliunits per liter. If overt hypothyroidism is diagnosed during pregnancy, levothyroxine should be started and titrated rapidly to reach and thereafter maintain serum TSH concentration at less than 2.5 milliunits per liter. Subclinical hypothyroidism, high serum TSH with normal free T4, has been shown to be associated with an adverse outcome for both mother and offspring, neuropsychological impairment. Therefore, women with subclinical hypothyroidism must be treated with levothyroxine and monitoring the bowel. After delivery, the dose of levothyroxine can be reduced to pre-pregnancy level. However, serum TSH should be measured 4 to 6 weeks later to confirm that the reduction in dose was appropriate. Screening of hypothyroidism in pregnancy. Also, professional scientists have previously recommended checking thyroid function in pregnant women who are asymptomatic or have a family history of thyroid disease. This approach may miss up to 1/3 of women with hypothyroidism. Therefore, universal screening for thyroid dysfunction is advisable in pregnant women or those hoping to become pregnant. So, key points. Primary hypothyroidism, low serum free T4 and high serum TSH, may be due to chronic autoimmune Hashimoto's thyroiditis. Iatrogenic causes, antithyroid drug, thyroidectomy, radioiodine, iodine deficiency or excess, or thyroiditis. Clinical presentations of thyroid hormone deficiency result from a generalized slowing of metabolic processes and accumulation of hydrophilic glycosaminoglycans in the interstitial space of the tissue, myxedema. Hypothyroidism usually requires lifelong treatment with synthetic thyroxine. Hypothyroid patients with a history of ischemic heart disease should be started on a lower dose of levothyroxine. Levothyroxine replacement in patients with untreated adrenal insufficiency can precipitate an Addison's crisis. Thank you for attention.